meeting is being recorded.
Alrighty. Right, as folks join in, I want to welcome everybody to our webinar series today. My name is Adil Alam, and I'll be your moderator for the webinar. So welcome everybody and all of our participants and your interest in the CMBS webinar series. A couple of announcements prior to starting. You may want to check our store for any previous webinars, slides, and recordings, which are also listed on our YouTube channel. So please make sure you go ahead and check that out. Also, CMBS always encourages clinical engineering programs and biomedical engineering departments across the country to consider a CMBS peer review. We are going to be updating our CMBS standards of practice to the 2022 version, I believe. So if you're interested, please do contact the CMBS Secretariat. So today we have a continuation of our webinar series. And again, this is being done in lieu of an annual conference due to the COVID pandemic. And in light of that, we will be reconvening in 2023 in Vancouver, BC, May 16th to the 18th. So please do mark those dates into your calendars. We're doing a lot of work in making sure that that conference goes well and then that we're safe in meeting once again. For the webinar, we're going to only be accepting typed questions and or comments. Anyone can submit those comments during the webinar, but we will be answering them after the end of the presentation. The intention is that we'll, after the quick round of intros, we'll spend about 45 minutes as part of the webinar content, and then the last 10 to 15 minutes will be question and answer. This session will be recorded and slides will be available to all registrants. And at this time, I'd like to hand it over to Marie-Ange to introduce our speaker and the topic at hand.
Thank you, Adele. So today we're very lucky to have Mochcine Elgarch. He is a biomedical engineer that works at the Directorate of Biomedical Engineering, Logistics and Supply, Ministry of Health and Social Services. Mochcine Elgarch began his career as a quality coordinator in clinical trials in Montreal. He then held the position of clinical engineer and project coordinator within various Quebec organizations and hospitals for more than 15 years, during which he participated in the realization of large-scale projects in health technology or information technologies. He currently holds the position of Senior Biomedical Engineer at the Ministry of Health and Social Services of Quebec for several years, within the Directorate of Biomedical Engineering, Logistics and Supply. He is the operational manager of the medical equipment reserved for COVID within the Ministry of Health and Social Services. He is joined as well with Francis Belanger and Maxime Villeneuve, and we will take questions in French as well and be answered in French if that's the language you want to talk. Thank you very much. Welcome, Mochcine.
Thank you, Marie-Ange, for this introduction. Thank you, Adil, for this opportunity. I think you're seeing my screen, yes. Just a few words of introduction. English is not my first language, so I ask you to please bear with me as I will try to do my best to make myself understandable. I would like to thank also Maxime Villeneuve and my colleague Francis Belanger, which are here to give me some moral support, but also they will have the opportunity to answer your question as well as me, as we are a team of clinical engineers. So let's get to the presentation today. This is a joint presentation from CMBES and APIBQ. So what we would like to introduce today is the clinical engineering in Quebec, the point of view of health authorities, because we have the privilege of working at the Ministry of Health in Quebec with Maxime and Francis. And this is more discussion. I want it to be a discussion and a way to share ideas between the big community of of biomedical engineer and technologists throughout Canada. So we start with that. So as a word of introduction, I will speak a few words on APIBQ, which is the Association of Physicists and Biomedical Engineering in Quebec. A few words on the organization of clinical engineering in Quebec. I will present briefly our directorate, our branch, DGBLA, the Ministry of Health. A few statistics around clinical engineering in Quebec, the domain, and a few examples of what we've done so far at the Ministry of Health, and specifically a centralized software, and a few examples of how our team are working collaboratively with local clinical engineering teams. And finally, a few challenges or a few topics to discuss or have a discussion about and ask a question on that. So APIBQ was founded in 1971. So like I said, it's the Association of the Physicists and Biomedical Engineering in Quebec. The founding members were 15, and now we are more than 200 professional members of the association. So basically, the goals of the association is to promote the production of and dissemination of knowledge related to biomedical technology, to ensure the safe use of technology, its optimal use, and to promote the synergy between its members. We also have webinars and the annual conference, just like the CMBES. I leave you the website address, so you can go there and consult the work that we are doing also in APIBQ. So I'll start with an history of biomedical engineering in Quebec that will give us an insight on how we have evolved throughout the time. So the first Institut de Génie Biomédical was founded in 1978. And this is a picture of the founding member that happens to also be the founding member of APIBQ. So we have a long tradition of biomedical engineering in Quebec. We also have what I've put there is a couple of universities that have some program around biomedical engineering or specialization or concentration, whether it is on a master degree, doctoral, or baccalaureate. So it's a couple of great universities. And also, I wanted to present l'Institut Transmedtech, which is a living lab. I think we had a presentation at the CMBES conference. It was 2019 of the biomedical engineer Carl-Éric Aubin. But that's just to illustrate the fact that we are working in biomedical engineering in Quebec for a long time, and that's a good thing, because this has allowed the APIBQ, the ministry, the health organization, the university to work collaboratively all together. So again, a few words about the work at APIBQ. This is it is in French. I didn't translate those, but this is some guidelines that APIBQ had produced over the years. So we have radio protection guideline, electrical safety guideline, a couple of guidelines that they have done at APIBQ. One of which is the Terminologie des équipements médicaux, which stands for standardized list of medical equipment. So that has been first produced by APIBQ, and then we are using it and making evolving this list within the Ministry of Health, with the collaboration of a couple of clinical engineers from local teams. So we will talk a little bit later on this standardized list. And on occasion, the ministry, we collaborate with APIBQ on the, particularly on group purchasing decision, but on any other issue, we collaborate with the local association of biomedical engineering. So I wanted to give a definition of clinical engineering. This is the definition by the American College of Certified Engineers. It is a professional who supports and advances patient care by applying engineering and management skills to healthcare technology. More particularly, the values that drive the profession is, of course, the safety. So this is the first value for clinical engineering. We have to make the safety of the patient and safety of the physician our first value, and this is the first question that should pop up in our mind when we're talking about healthcare technology. Also, it has to be appropriate, so we have to have the right technology within the right setting and at the right time for the right patient. So this is also an important part of what it is to be a clinical engineer. And finally, we have to ask ourselves, what is the best value for the money that we are putting into this health technology. So why do we need clinical engineer? Well, obviously, you know that technology is complex. It is costly. It has a high cost, and there is a need to manage the limited financial resources to get the best value for the patient. And of course, in Quebec, but I think all around Canada, biomeds are continually confronted with demands for new biomedical technology, so new healthcare technology, while being asked at the same time to manage the existing inventory and existing technology. So we have to find the right balance between these competing interests. And I think this is what characterizes the clinical engineers. We have to find the balance between all those interests and give the appropriate answer. What I wanted to illustrate with this picture is that the physician needs the equipment to give the healthcare service, to give the services to the patient. So we are responsible to make that, to assure that the technology is safe and that it is the good technology and that we bought it at the right with the right price for it. So how clinical engineering is organized in Quebec? It's a two-part component. We used to have a three-part component. We used to have regional healthcare agencies that were in charge of more operational work with the healthcare organization. But since a reform that what took place in 2015, so it was 7 years ago, now it's only a two-part component. So we have the Ministry of Health, which is in charge of giving the guidelines, the regulation, in charge of doing the allocation of the budget. And we have, it's not under it, but we have the healthcare organization, which provide the healthcare services. And within the healthcare organization, the way we organize in Quebec is that every part of the province, every region of the province have a centralized organization that we call Centre Intégré de Santé Services Sociaux. So this centralized organization is basically a big healthcare organization that have a couple of hospitals and a couple of retirement home and all of our healthcare installation act for the that are regrouped in each of those healthcare organizations. So within those healthcare organizations, there is local clinical engineering teams. So we can say that each healthcare organization have a local team of clinical engineer or professional that are in charge of managing the medical equipment, with the exception of the smallest organization, the smallest one, which are in the north of Quebec. So the communities and small communities and small territories in the north of Quebec, which has they don't always have a team of clinical engineering dedicated. But for the most part of the healthcare organization, there is a team of clinical engineering. And for us in the Ministry of Health, what is interesting is that we also have a team of clinical engineer, and I work in this team with my colleague Maxime and Francis. So that allows us to talk from clinical engineer to clinical engineer, from the clinical engineer of the Ministry of Health to the local team of clinical engineer. We talk the same talk, we have the same references, so it's really easier for us to provide the guidelines or to exchange on any subject that arise around the medical technology. And to give you an insight on our organization, we are under the leadership of our Associate Deputy Minister, which is Mr. Luc Desbiens, which is also an engineer. And within this branch or directorate in the ministry, what we found, we have a team that is in charge of the new construction project and expansion project and development for all healthcare institutions. So we're talking about a major expansion project or buildings. So this is what we call DPI. So they're colleagues of us. We are in the same team, but we are in the same branch, but this is another team, but we're working closely with them. We have another team, which is DCE, which is in charge of the maintenance of the building and the renovation project around the building. We have a third team that is in charge of the financing of all the capital equipment and buildings. So the work done by the two previous teams, the third team provide the financing of that. And finally, we have our team, which is DGBLA, which contains the team of clinical engineer, but also a team of logistic and purchasing team. So we can say that globally we are under, if I want to compare with a local healthcare institution, we can say that we are as if we were under the direction of facilities management. So we will see a little bit later, I will explain where the clinical engineers are situated in the direction of the healthcare institution. So our team, I will say it in French. So DGBLA is Direction du Génie Biomédical, de la Logistique et de l'Approvisionnement. So what I have translated by Department of Biomedical Engineering, Logistics and Procurement. So within our team, we have the team of biomedical or clinical engineering, which I'm part of. We have a team of in charge of logistic and operational support. So at the Ministry of Health, we have a team in charge of the guidance and guidelines around the procurement and purchasing. We have a team around radio protection. And finally, we have a team in charge of the pandemic strategic stockpile. So during this team didn't exist for obvious reason before the pandemic, before the COVID pandemic, and now we are in charge of the procurement for the stockpile of the government in Quebec. So our responsibility for each of these teams, we have the same responsibility within our domain. So for us, this will be to define the strategic alignment in line with the government expectation and the strategic plan of the MESS. So we issue strategic guidelines, we issue guidance, we issue documents, and we also issue objectives for the local clinical engineering teams to attain the desired performance. We also have defined and we have implemented communication structures with our healthcare institution. I will talk a little bit about that later. We also monitor the performance of the healthcare institution in regard with the strategic alignments and guidance document. So a few words on a few stats on clinical engineering in Quebec. So we are 8.5 million people in Quebec. So we have 34 healthcare organizations. So what I've talked a little bit earlier, which has the major group, regional groups of healthcare institutions. So they are regrouped into 34 healthcare organizations. The replacement value for all the medical equipment for the province of Quebec is around 4 billion. So that's our replacement value for all the equipment, and the annual replacement budget is $300 million. So this annual budget is what our team of clinical engineers at the ministry, we have to do the fair allocation of that towards the 34 healthcare organizations. So we are doing the allocation for of this budget for that. And also, I will, if we have a couple of minutes later, we will talk about the process of identifying the required budget. And for what I introduced earlier, this is from our clinical engineering team. So this is the department with which they are integrated, or their leadership. So we can see that for us, 57% of clinical engineering are under the leadership of facilities management within the local institution. About 20% are under the leadership of information technology, and about 18% are under the leadership of a clinical service. So what we call the clinical services, it might be imaging or laboratory or ancillary services, but it's clinical services. So they talk to they report directly to a clinical services. And for a small part, they report to logistic and supply. We also have in Quebec some major projects. So we have major hospitals that we are building, and this is I think this is around 2 billion per year, but we are planning on those major projects. But it's a little bit tricky because there's a lot of projects, so it was a little bit tricky to get some data around this. Okay, so how is the work done in Quebec? How what is the proportion of work? So this is a simplified view of a life cycle of medical equipment. So we find the planification of the acquisition of the equipment, the procurement phase, the use and maintenance period, and finally the recycling period. So what we can see is that for engineers and other professionals, 55% of the time is dedicated to the procurement process. So the activity of doing the RFP, collecting the evidence, talking to the manufacturer, to the distributors. So 55% of the time are dedicated to this type of activity. 10% of their time are dedicated to the planning, so equipment planning, whether it is planning on the long-term or short-term period, and 25% of their time is dedicated on the use side. So to resolve issues that may arise with the equipment, or to participate in the installation of the equipment. So the installation project of the installation part of the project of acquiring an equipment, biomedical equipment. Also, all that is answer to the recalls or alerts, medical alerts. So that counts for 25% of their work. And from my last survey, we were 200 to 300 professional engineers and others that work in this kind of activity. For the part with the technology, for the technologist part, what we see is obviously most part of their time are dedicated to the maintenance of the medical equipment. So 85% is dedicated to the maintenance, whether it is preventive maintenance or corrective maintenance. They also give some advices on the use of equipment, and only a small part of their time are dedicated to the procurement activity or to the planification activity. They also work on the recycling activity, but it's more it's not that big of a deal in the allocation of their time. And like I said, the last time I done a survey, I think the technologists in Quebec were around 450 to 500 tech. But this data should be used with caution, because it is not verified. It is my guess. So I think it's good data, but it is not verified. So you have to take a grain of salt with this data. But that gives us a portrait of how clinical engineering is done in Quebec. So one thing that we have done for the past 14 years at the Ministry of Health, and I think this is a cornerstone for us. This is the first. This is the major tool that we're using to give the guidance and do the management of the provincial medical equipment. Is that we've put in place a strategy, a provincial management strategy for medical equipment, which is based on an IT system, an information system. So it's an application that has two modules, and this application is accessible for all the healthcare organization. So all the local clinical engineering teams have access to this application. So it has two modules. The first one is what we call the national inventory. So it is an inventory of all the strategic assets that we have in Quebec. It contains the device costing more than $100,000, or the device that have a more strategic nature. So, for instance, if I want to give an example of how we used this tool during the pandemic, we had a period when everybody was looking for ventilators. So for us, it was really easy to say, okay, we know exactly how many ventilators we have in the province. We know where they are, and we know their state of. We know if they are ready to be used, or if they need some work done before being used. So this has proven really useful during time of crisis, and whenever there is a crisis around medical equipment, and for instance, if there is a big recalls, or we can go in this tool, check the inventory, and this allows us to do a proper analysis of the situation and know are we going to be impacted highly from any situation, or that the situation won't concern us because we don't have those type of equipment. So this is really a useful tool for us to establish the strategy and the guidelines with regard to the medical equipment. So the second module that we have within this application is the replacement plan, a medical equipment replacement plan. So all the replacement requests for medical and non-medical device goes through this system, so that we can authorize those requests. And also this is also like I said earlier, when we do the fair allocation of the budget, then it is reflected in this application. So when for instance, the local clinical engineering teams decided to do a provision for a project, they can go on the application and do the provision, and all the information, the budget will be balanced on this application. So this application ensures an effective and efficient management of the capital equipment and resources that we have for medium and long term, and also it allows us to establish common management rules. So for instance, this is the same rules that applies whether you're in Montreal or if you are in a rural setting. The same rules applies everywhere. And after that, we have some flexibility. We had some flexibility in the system, and that's where the clinical engineering role and teams plays a part, because after you put the rule in place, then you have to have the flexibility to apply the rule or go a little bit around the rule to make a situation, to resolve any issue that may arise. So so if we go into the detail of the application, so we have what just said, the provincial inventory. So something that the inventory has is that we're working on a make model basis. So the way we register the equipment, of course, we have the standard description, but we also have by make and by model. And that gives us, like I said earlier, when in time of crisis, or if you have a major recall from one brand or one model, then we can say, okay, are we impacted by that, or we're not impacted? So the fact that we have a make model, that's is really an advantage for us. And also we have the date of purchase or installation of the equipment within the healthcare institution. So those two information will provide us some insight when it's time to do the medical equipment replacement plan. We also have the list we're providing through this application. We're providing a standardized list of medical equipment for all our local clinical engineering teams. So we all have the same data. So and we have the standard description, which sometimes proves tricky to do a good description, but we have that. We have the lifetime expectancy of the equipment, and we also have the what is the replacement value of the equipment. So we provide this list, and so that allows us, the healthcare organization and the Ministry of Health, to share the same model of data and values for the equipment. So this allows for standardization across the province. So for instance, if for instance we say, okay, typically a CT scan is a 10 years lifetime expectancy, then it is 10 years for Montreal, and it is 10 years for Gaspé, or it is 10 years for Quebec. It's the same value across the province. So we have the standardization across the province, and we don't have to deal with each and every one of the healthcare organization on a one-on-one basis. So we said, okay, this is the common rules, so everyone have the same rule with the same data. Another thing that is really interesting that we've done, that we are doing within the Ministry of Health, is that we have a committee with a couple of engineers from the local clinical engineering team, so from the hospitals, and we are meeting with them regularly to update the list. So we have a meeting every 6 weeks or so, and we review the list, we review the lifetime expectancy. If there's some changes, we review the replacement value. If there is an evolution on the price paid by the for acquiring the equipment, so we review that on a regular basis. So it is a continuous work that we are doing to stay up to date with the market and with the local clinical teams, and so we make sure that this is a tool that is always up to date, and we can base our decision on that on those description and this list. And also with this committee, this is the place when we put some new equipment on the list. We retire the oldest description of the list, or we modify the description or the data. So this is an important part, because we're not doing this alone at the ministry, but we are collaborating with the local clinical engineering teams to get the best data that we can. Okay, another aspect of the system is the medical equipment replacement plan. So like I said, now that we have the inventory of all those strategic assets, and we know the date of installation, and through the standardized list, we know the replacement value and the lifetime expectancy, we have the first step of medical equipment replacement plan. So, and like I said, this is a standardized process throughout all healthcare institutions. And after that, the healthcare institution and local clinical engineering team are encouraged to add some more criteria to that, okay? Because it's too simple to say, okay, I bought this piece of equipment 10 years ago, so now it's time to replace it. Obviously, you need a little more, there is a little more complexity to that. So sometimes you have end of support. So you need to replace a little bit early the equipment. Sometimes you have a standardization of make and model. So for instance, if a healthcare institution said, okay, I would like to standardize to one model or two model of equipment in this installation for the sake of diminishing the medical error, or for to make easier for the nurses to have only one or two brand to know how to operate those equipment. So that is a justifiable reason. Also, we have economical reasons. So for instance, if the local team said, okay, I think it's not economical anymore to maintain this piece of equipment, or the next reparation will be really costly, and we don't see that, and we evaluated that it will be better to replace it now than to wait for the date of replacement, the automatic date of replacement. So that's also a reason that we can replace the equipment more early. And finally, for strategical reason, sometimes you have some strategical reason in the healthcare institution, and for this reason we have to replace the equipment. But we always keep in mind, like I said, the free value of the clinical engineers is that we need to provide the safe equipment, appropriate, and also for the best value. So I will try to speed up a little bit. So what we're trying to do at the Ministry of Health, because obviously if everything were automatic, we won't have to work. So we won't have to do our activities. But what we're trying to do is, sometimes we have, with the experience, we see healthcare institutions that are asking for really expensive product, and then we're trying to put them into to orient them toward less expensive equipment, and we ask them to produce cost-benefit ratio analysis to justify the need of what they are requested to do. And sometimes we know there's a lot of pressure from the physician or from the director to go with the expensive equipment, but that's where we have to step in and say, okay, maybe there's a solution that will be less expensive, but will do the work also. So for the processed medical equipment replacement plan is a 3-year plan that is annually updated, and we do a coordination with our group purchasing here in Quebec for the major equipment, and also it needs the approval of the CEO, the CEO of the healthcare organization, and there's the same process for all the renovation projects that are associated with the installation of the medical equipment. So we're trying to have a coordinated approach toward the replacement of equipment. So as you may see, the importance of data is really important for this application to have the good data. So it is a communication tool between the ministry and the healthcare network. So it must be up to date, it must be truthful, and it commits the professionalism of the person when they get the information. So a few examples of what we've done. We also, through our discussion and collaboration with local clinical engineering team, we have allowed to take a little portion of the replacement budget to acquire to add equipment, actually, which is not replacing the equipment, but add a little bit of equipment here and there to either to solve small issues or to automate process. For instance, there was a manual process and then we're going automatic. So we have put in place a small portion of the budget that allows the local team to do that. We also, to help increase the delivery of the project, we also have put in place a budget to finance extra human resources. So it goes 100, 200, 300, depending on the size of the healthcare organization. And we've put in place a committee of biomedical managers. So we're talking to the biomedical manager. We're talking to the biomed on a regular basis to know about their issue, their local issue on clinical engineering, but also for us to give information and talk about strategies or management strategies. So we have this group of biomedical manager, and this is a big success for us because it is a way of having this structure of communication between the Ministry of Health and the local clinical engineering teams. So basically, I've just summarized our work on this, reflecting the life cycle of medical equipment. So what we say is that we are working on the budgeting of the to do the provision, to do the allocation for the healthcare institution. Then we have the planning part, which is in the application. We have the purchasing part, for which at the Ministry of Health we are working closely with the group purchasing to take some strategical decision. Also, we have produced a guideline for the reused or recycle of equipment, and also that contains a portion of international donation. So we ask our local teams to go through internal donation when they want to dispose of their equipment. And finally, we also are monitoring and reporting the performance of the local clinical engineering team. So as a conclusion, or as a few challenges that we might have on the horizon. So of course, the aging of the population will be a major topic for us. The increase in chronic disease and the increase in home care medical equipment. So managing all those equipment will be a challenge for us. economical is always, there's always a big pressure to try to reduce the economic impact of healthcare technology. So that should be something that we are that we put our focus on. And for the example, what I illustrate is that for Quebec, the healthcare is a little bit more than 43% of the national budget. We have challenges on the technological part, and specifically with the big data, the integration with the IT, and all that is artificial intelligence. So that those applications and those equipment are starting to get into the healthcare network. So we have to put our focus on that. And finally, on the size of the regulation, we have the cyber security issues that we have to put a focus on, and that will be will be our challenges for the next couple of years. So thank you, and we will take the question now.
Thank you so much for your wonderful presentation, Maxime. We learned so much, and I've learned so much about what Quebec does. It's interesting. We have a question for Marc Giroux. He